My name is Tess, and I'm one of the UCLA general surgery residents. Thank you for having me here. And I'm going to be presenting on patient hospital factors that influence surgical approach in the treatment of acute cholecystitis. Do I just press here? Uh-oh. Okay, we have no disclosures. All right, so in the United States, over 200,000 patients are diagnosed with acute cholecystitis annually. And there are two options for their surgical approach. It's minimally invasive or an open surgery. As we know, laparoscopic surgery is considered the gold standard given worsened outcomes with open cholecystectomies, which have increased morbidity with 2 times the wound infections, 2 times pneumonia, and 5 times increased mortality, along with a length of stay that's 5 days longer. However, we also know that a subset of the minimally invasive patients will ultimately get converted to open. And these patients, too, have worse outcomes with 3 times the morbidity, 3 days longer length of stay, and then increased costs, even if you're comparing these patients to the long laparoscopic cases. So our objective is to examine the patient and hospital factors that underlie differential utilization between minimally invasive surgeries and open cholecystectomies indicated for acute cholecystitis. I just shown that patients who undergo an open cholecystectomy and conversions have worse outcomes. So our whole hope is to decrease those surgeries in the future and ultimately to eliminate open cholecystectomies. I'm going to be presenting the data essentially by asking 2 questions. Who is undergoing which surgery? Which patient and geographic factors affect surgical approach? And where are these surgeries occurring? Which hospital factors affect surgical approach? To do this, we looked at OSHPT data, and OSHPT stands for the Office of Statewide Health Planning and Development, and it captures inpatient data from patients discharged from licensed hospitals in California. So we looked at data from 2016 to 2018 and included patients with a primary diagnosis of acute cholecystitis and an ICD-10 procedure code for cholecystectomy. In order to more accurately capture the acute cholecystitis population, we excluded patients with a length of stay less than 1 in non-ED admissions, and this left us with about just over 40,000 cholecystectomies for acute cholecystitis. We then captured the following patient, geographic, and hospital characteristics, as well as the surgical approach. In our total cohort, 98% of patients underwent a minimally invasive surgery, at least initially, and 2% of patients underwent what I'm going to be calling a primary open cholecystectomy. Our conversion rate in this population was 4.3%. So we're going to be starting with the first question and looking at patient and geographic factors that affect surgical approach. So we first compared patients undergoing a primary open cholecystectomy with the patients that get at least an initial minimally invasive cholecystectomy. And you can see here that the only patient geographic factors that were statistically significant were age and male sex. If a patient was 40 to 65, they had an odds ratio of 2 of undergoing a primary open cholecystectomy versus at least minimally invasive initially. If they were over 65, their odds ratio is 2.5. And if they were male, the odds ratio was 1.7. We then compared the patients who had a conversion to open with patients who remained minimally invasive, and we found nearly the same results. So again, if you were between 40 or patient was between 40 and 65, they had an odds ratio of 2. If they were over 65, they had an odds ratio of 2.6, and if they were male, their odds ratio is 1.8. Lastly, we compared the patients that undergo conversion with the patients that get a primary open cholecystectomy. And here we found no differences in patient population or patient characteristics and geographic characteristics between the 2 cohorts. So in summary, when we look at which patients are receiving primary open cholecystectomies and which are receiving conversions, they appear to be the same. And these patients are male patients greater than or equal to the age of 40. In our initial analysis, we saw that there were certain characteristics like teaching status, safety net status, and cholecystectomy volume that impacted surgical approach. And so we decided to look more into the hospital factors. When we looked at teaching status, we saw that compared to non-teaching hospitals, teaching hospitals had a higher odds ratio of performing a primary open cholecystectomy with an odds ratio of 1.5, and also had a higher odds ratio of conversions with an odds ratio of 1.3. We did a similar analysis with safety net hospitals and got similar results again. The odds of a primary open cholecystectomy were 1.4, and the odds of a conversion was 1.2 when you compare safety net to non-safety net hospitals. And then lastly, we compared the highest quartile of cholecystectomy volume hospitals with the lowest quartile hospitals. And here you can see that there's actually no difference, no statistically significant odds ratio when it comes to performing primary open cholecystectomies compared to minimally invasive. However, lower volume centers have a higher odds of performing conversions, and the odds ratio is 1.5. So in summary, the patient geographic factors that ultimately affect the type of surgery a patient gets are age and male sex, and the hospital factors are teaching hospitals, safety net hospitals, and low volume hospitals. So I'm going to use an example to look at a patient and evaluate their risk of undergoing a conversion. So we'll take our high-risk patient. So this gentleman is over 65 and a male. If he presents at a teaching hospital that's also a safety net hospital, that's also a low volume hospital, the odds of him undergoing a conversion are 6.5. And this just sort of hammers home the point that this type of patient may need a different approach, because we know that conversions even have worse outcomes than a minimally invasive cholecystectomy. So for future directions, we can evaluate and look more towards preoperative and operative mitigation strategies, especially with the use of AI and improved technologies. That's something that we can implement. And actually, at one of our affiliate hospitals that has a male predominant population, we're evaluating laparoscopic versus robotic surgery for the management of acute cholecystitis with very promising results and extremely low and absent conversion rates with the robot. Okay, and then lastly, the limitations of this study is this is a database study, so there could be inaccurate data, incomplete data, and then the inability to capture patient comorbidities. And lastly, we weren't able to evaluate robotic versus laparoscopic surgery separately. I'd like to thank the following people, and I'll take any questions.